the outset, they start fairly distinctly, the two areas, the cortex and the medulla, and that whilst they're together in the final organ, they function quite differently. And the cortex really is an endocrine organ, and the medulla is essentially part of the autonomic nervous system. Just for exam purposes, cortex comes from intermediate mesoderm of the urogenital ridge and develops from 5th to 8th week of gestation. Medulla comes from the neurocrest cells and 9th to 18th week of gestation. Something I don't think I quite realised was the fetal adrenal gland does weigh twice the weight of the adult gland, and the cortex undergoes a degree of atrophy over the first year of life, and the reticulation doesn't complete development until 3 years of age, and that really just that's because the sex steroids aren't really necessary for the first few years of life. So the anatomy, I think you know this very well, or you've seen adrenals. So they're paired retroperitoneal organs. They have medial and lateral limb. The form of the cortex medulla, as we said, and they're only small organs, 4 to 5 grams, 4 to 6 centimeters approximately in size. Tend to lie just above the kidney, hence the previous term of suprarenal glands. And they can lie medially to the superior pole, but usually if you dig around at the upper end of a kidney, you'll come across it at some point. Lie within gyrus fascia, so very much within that renal mass. The right adrenal, and I'll come on to this when we discuss the surgery in a little while. The right adrenal is essentially nuzzling into the IVC. Liver lies above it, and so get liver up and the IVC across to get to it fully. The left adrenal is sitting on the aorta, and with the other structures around, obviously the kidneys closely approximated to them. And with the left adrenal, the things to be careful of, the pancreas really, that's sitting there, the stomach to an extent, but it's more about the spleen and the splenic vessels that are in the way of that one. I think you know your anatomy, so that's where they sit. A couple of fairly old pictures. The picture on the left is posterior view, so just with the colon overlying it on the other side. So from the surgical point of view, this is probably the more important thing. So the arterial blood supply, it's variable. It comes from 3 arteries, superior, middle, and inferior adrenal arteries. You rarely ever, I don't think I've ever seen an adrenal artery as such, that they just very small vessels, and either divided after a bit of diathermy or a small clip on them, but it's rare to see a proper artery, but that they do have formal arteries supplying the adrenal. The drainage is much more reliable. On the right side, it's quite a short drain, goes in fairly obliquely into the IVC, quite high. And often you really have to get the liver out the way to get to that vein fully. On the left side, it's long, it's joined by the inferior phrenic vein at some point, drains into the left renal vein, then obviously into the IVC. Goes to, lymphatic wise, goes to the paracaval lymph nodes on the right, the paraortics on the left. So again, this is really for the exam side, I think. Thinking about it as 2 distinct organs, the cortex produces corticosteroids, that's mineralocorticoids, glucocorticoids, and sex hormones. They're all synthesized from cholesterol. I haven't got into the process of that cholesterol formation. I thought that's probably a bit definitely outside of the scope of what I do, and hopefully outside your scope. So the zona glomerulosa produces aldosterone that acts on the distal tubule in the kidney, increases sodium and chloride reabsorption and water reabsorption, and increases potassium secretion. That's very important when we come on to talk about Conn syndrome in a couple of minutes. The fasciculata produces glucocorticoids, mainly cortisol. These have the effect of raising blood glucose level. They're anti-inflammatory. They inhibit bone formation, inhibit collagen synthesis, hence the thin skin, fragile capillaries you get. and cause protein catabolism. So you do get the muscle wasting and weakness. And again, we'll come to that when we talk about Cushing's syndrome in a moment. The zona reticularis, estrogens and androgens, don't see so much of this at all. But obviously with the disorders of very young patients with the congenital adrenal hyperplasia, that's more comes into the pediatric field than what we would sort out. So the medulla, again, it's chromatin cells, catecholamines produced. They're produced from amino acids, tyrosine, and they do form really part of the autonomic nervous system. The metabolism of the catecholamines is important for when we're diagnosing things like pheochromocytomas later on, so metanephrine, norepinephrine, and VMA. VMA used to be a test that they did for pheos, but it's not so much anymore. And we'll talk about that in a short while. So some of the disorders I thought we should cover: Cushing's syndrome, Conn syndrome, and pheo. And really, they're the most common ones we'll see when the endocrinologists get us to take out adrenal glands. Adrenal carcinoma, we'll talk about a bit. It's vanishingly rare. We'll mention it because it's quite important, but it'd be unusual to do more than a couple a year of those, if any. So the background of Cushing's really is the hypothalamus anterior pituitary adrenal cortex axis. The release from the hypothalamus of corticotropic releasing hormones is really quite tight, tightly controlled. So there's a circadian rhythm to it, so lowest levels around 11 p.m, highest level in the morning, and hence the schedule of testing that's done. Because it's so tightly controlled, any variation around that can be considered abnormal. But when you do get variations, there's various causes. By far the most common cause is the use of steroids. So whether that's topical, oral, or even the anabolic steroids will all push it up, and that's mainly what's seen. The more inherent cause is the ACTH dependent, ACTH independent, depends where the release is coming from. So the pituitary adenomas will cause the ACTH dependent, that's the classical Cushing's disease, whereas the adrenal cortex releasing excess cortisol is really what we get involved with the adrenal surgery, and that's really only 10% of the Cushing's syndrome. But that's probably the most common reason we're taking out adrenals at the moment. So just for the clinical side of things, the classic symptoms of Cushing's syndrome, they tend to be overweight with the central obesities, the moon faces buffalo hump, the muscle weakness, the easily bruisable skin, and the abdominal stray. And you do see these, whatever the cause of the Cushing's. But in a good going case of adrenal Cushing's syndrome, then you can get all of these features as quite pronounced. Looking back to what we said cortisol did, it explains really the obesity, the poor lipid control, the diabetes, at least the insulin resistance, leading to hypertension. You get weak bones, and in men you can get hypogonadal hypogonadism. Don't see it so much, but it can occur. Subclinical Cushing's syndrome, which we mentioned previously briefly, it's an increased level of cortisol with an adrenal nodule, but they don't really have any clinical signs, and really it's picked up on investigation of incidentalomas, about 10% of them. And there's increasing evidence really that removing the adrenal causing subclinical Cushing's has some beneficial effects for health as patients go on. So I think we are moving to taking more and more of these out, especially a fit and well patient who's got a good other adrenal gland. So Cushing's syndrome, classically diagnosed on the overnight dexamethasone suppression test. the small amount of dexamethasone given the previous evening, cortisol was measured the following day, and think about the feedback loop that we saw a moment ago just on the axis. So there's negative feedback going from the adrenal cortex to pituitary and the hypothalamus. That low dose of dexamethasone should suppress the ACTH and the cortisol levels. If you've got the presence of hypercortisolism, it shows that, but it doesn't show you where that's coming from, whether that's the pituitary or the adrenal. But a serum ACTH should allow you to differentiate between the two. So if the ACTH is low, you should have an independent pathology from that pituitary. So then lead on to go to do the imaging, hunting for an adrenal mass. This horrid slide is the next bit, really. It's about Conn's syndrome, saying excess aldosterone. So Conn's syndrome should be the independent secretion of aldosterone, which is not controlled by the classical axis of the renin-angiotensin aldosterone system. With the increased aldosterone, that acts on the distal nephrons in the kidney. And I don't know about your exams, but we always ask about where in the kidney these things act, and it's just memorizing it. It makes no difference day to day what we do, but it's just memorizing that. So you get increased sodium reabsorption, increased potassium secretion. So classically with Conn's syndrome, primary aldosteronism, you get hypertension due to the water uptake, get low potassium. You don't generally get hypernatremia just because it's the water uptake dilutes the excess sodium. So look for Conn's if you've got hypertension or you've got hypokalemia. And we'll come on to that there with the incidentalloma pathway later on. The morning aldosterone concentration tends to be measured as with the renin activity, and then the ratio of that is used to calculate the likelihood of primary aldosteronism. The difficulty with Conn's is that even if there's an adrenal adenoma or lesion on a CT scan, it's not necessarily a source of excess aldosterone, and the vast majority of primary aldosteronism is due to bilateral adrenal hyperplasia, and about 60% comes from that. So even if you've got an adrenal lump, you don't necessarily know which side it's coming from. CT and MRI aren't particularly reliable for that. And Conn's tumours can be very small, so a fifth of them are less than a centimetre. So it's quite hard just to go on normal imaging to determine if there's something that needs to come out. Patients tend to get sent for renal vein sampling, which I think they do some in Derriford, they do it up in London, and patients will usually be sent quite far for it. It's quite a difficult and inaccurate science, as I understand. But essentially, cannulated in one of the femoral vessels, and then the IR should go up and try and sample from each vein. It should be an adrenal vein, not renal vein, sorry, and also the IVC to allow comparison. And generally that'd be done to find which side we need to take out, if any. The only criteria when we wouldn't need to do that is when they're less than 40 years old and the lesion's more than 2 centimeters in size, in which case there's an argument to say the radiology is less equivocal. So pheochromocytomas, they're the sort of one condition which gets people a bit more interested in adrenal surgery, or at least the anaesthetist anyway. And this, obviously, the last two conditions we heard about were from the adrenal cortex. This is based on the adrenal medulla, so it's essentially part of the autonomic nervous system. And that fits really with the cells that are overproducing the hormones here. So the chromatin cells of the sympathetic ganglia. They're very similar, but they contain extra enzyme, PNMT, which is able to convert epinephrine to norepinephrine in large volumes. They're not common, they're quite rare, and we only do a few a year, so 1 to 2 per 100,000. Does form up to about 5% of incidental adrenal masses, though, which is why it's worth screening them for. However, about 25% of them aren't within the adrenal gland itself, and if there's raised or suspicion of pheochromocytoma, then there is quite a bit of effort looking for other sites as well as an adrenal site. So head and neck, thorax, abdomen, pelvis, other common sites. I've seen them in the bladder before. There's one in Taunton recently where someone's doing a resection of a bladder tumour and the patient was very unstable anaesthetically. They had a similar one in North Devon not that long ago. Apparently a very common site, not that I've ever seen it, is the organ of Zuckerlandi, never heard of it, which is between the aortic bifurcation and root of IMA. I just put it in because I suspect that's the type of thing they could ask, but no one really, practically it's not that useful. The thing that we have to think about PHEOs as well is that about a third of them are familial in origin. So there's quite a few genes that have been identified as associated. Probably one to hear most about is the succinate dehydrogenase subunits B. Neurofibromatosis type 1, we see some of. Don't see so much associated with von Hippel-Lindau or that Kanaka, and it is associated with multiple endocrine neoplasia 2. So classically, the PHEOs will be the 10% tumour, so 10% extra-adrenal, 10% familial, 10% bilateral, 10% paediatric, 10% malignant. I think that's fairly historic now. At least probably about 30% are familial. So it's a convenient, nice number, but I don't think I'm not sure exactly how reliable that is now. You probably know more about the clinical presentation. So there's the classic symptoms: headache, perspiration, tachycardia, and they can be paroxysmal, but there's lots of patients often have anxiety, the sweating, the episodes of high blood pressure, and patients will be asked to keep an eye on their blood pressure. It's suspected and monitor at home. Up to about 20%, however, asymptomatic, which I can't quite understand, but we've had a couple recently we've taken out PHEOs for, which have been asymptomatic ones, and it's taken out on the assumption that they are going to. There's a chance they could be malignant, but also they could cause symptoms later on. So the hereditary ones tend to be present at a younger age. They're more likely to be bilateral or multifocal. Depending on the gene abnormality, it may depend more on where they are. So the SDHB or more risk of malignancy, but others, the endocrine neoplasia associated ones tend to be from the adrenal gland, whereas VHL and von Hippel-Lindau and neurofibromatosis type 1 tend more like to be extra-adrenal. The difficulty with PHEOs is that we've heard that 10% can be malignant. There's no real histological criteria to suggest what is malignancy and what's not. It's defined only really by the presence of metastasis. As we just said, the succinate dehydrogenase subunit B is more likely to be associated with malignancy. And the bigger the tumour gets, the more likely it is to be a malignant one. So over 5 centimetres tends to be the size of PHEOs when there's concern of extra-adrenal sites. And if it does go elsewhere, it tends to go to the bone, lung, liver, and lymph nodes, and obviously the initial lymph drainage, as we mentioned in the anatomy section. So the testing for PHEOs, it's based on that metabolite of catecholamines, and that occurs within the adrenal medulla. And so mainly we're looking for norepinephrine and metanephrines. They are produced in varying amounts. It depends on the type of tumour and what they're producing. Really, is what the predominant form is, and often the labs will test for both norepinephrine and metanephrines, and they'll come in a report of metanephrines, and then there'll be a breakdown of which is raised. Generally speaking, there's two ways of testing this. So you can have the plasma test, so plasma-free metanephrines, and positively if it's more than 2 times the upper limit of normal. There's also a 24-hour urinary metanephrine, and one guide is to say to do those if the plasma results are less than twice the upper limit of normal. There's no classic signs. In reality, what we find is various people get involved in the diagnosis of this, and patients often have had them both done anyway. It doesn't usually matter. It rarely muddies the water too much. If there is doubt, the endocrinologist will do a clonidine suppression test, and clonidine is an alpha-2 agonist, and this suppresses the production by the sympathetic nervous system of the catecholamines, but not by the PHEOs. So it's given initially, then and then a blood test, and then in 3 hours' time. And if the production of catecholamines is still up, it's more likely to be the PHEO. I think it's rarely needed to be done, that test, but it's definitely one would be done by the endocrinologist, not us. There's various ways of imaging for PHEOs, and again, the patients tend to have a bit of a hodgepodge of approach to how to find them. Often it's incidental, or there's been some effort to actually find a source of the increased catecholamines. But CT is fairly good. If the lesion on non-contrast CT is a non-contrast CT scan is important to get for these lesions. If it's more than 10 Hounsfield units, it could be a PHEO, and they generally PHEOs are not under 10 Hounsfield units. They've got a good blood supply and generally have a low lipid content, as opposed to adenomas. They do not have a rapid washout, so the contrast will stick around. You've probably heard about the CT with washout, and that's essentially what it's looking for, to see how quickly the contrast goes. MRIs tend to be a good alternative modality. We tend to do MRIs if the CT is suggestive of a PHEO, and we're not quite sure on the planes between the different structures, because if there's any localized invasion, then it's obviously a different kettle of fish just to a localized PHEO and an adrenal, so it's more surgical planning, but they can be used for diagnosis. And the two nuclear medicine scans, so the MIBG or the PET scan, there's quite a bit of crossover in their use, and the MIBG is the scan that's been around for the longest. It's tagged generally with iodine 131 or 123. I think locally we use 123, and it's good for assessing extraadrenal sites of the PHEO, any metastatic deposits, or recurrent pheochromocytoma. So if someone's had their PHEO out, they're kept an eye annually, usually with metanephrines. If that goes up, then they could have an MIBG to see if it's cropped up anywhere else or locally. The advantage of doing one pre-op initially is that you know if it's MIBG avid, in which case MIBG can be used again for looking later down the line. The trouble with MIBG is that not all PHEOs are highlight on them. And that tends to be familial ones. So if a patient's young or there's a genetic element to it, or both probably, tend to use a PET scan, because you get cold scans if the SDHB gene and VHLG mutations are present, and they won't flash up on the NIBG. And equally, if they're very aggressive lesions, they can lose their ability to accumulate MIBG, so in which case we do a PET scan. So if the patient's young, or you're worried about cancerous pathology, then a PET scan is probably better. And when you're sort of increasingly doing PET scans, so if it's a large mass or there's familial, then a PET scan would be better. And that brings on genetic testing. So if there's any of these factors present, the patient gets sent off to the genetics department, who will have a look to see if there's any of these underlying genes. So family history, under 50 years old, if there's multiple sites, if they're malignant or it's bilateral, then there's a good argument for getting them sent off for genetics. So I said I'd just mention the adrenocortical carcinoma briefly, and it is vanishingly rare. So I think I've seen 1 or 2 cases in the last year. Both have been very extensive and unresectable. So we don't see many at all. As we get older, the chance increases of getting them, as well with the lesion size, and we'll come on to that when we talk about the incidentalomas again. There's a peak in their incidence in the first decade of life, and obviously we don't see that locally, and they get sent off up to Bristol if any of those come up, and in 40 to 50s. But I think the ones we've seen have sort of fitted this later age, if not a little bit younger. Females slightly higher level, slightly higher incidence, and it is associated with some of the syndromes, genetic syndromes, so multiple endocrine neoplasia 1 in this case. They tend to be secretory, with increased cortisol is most common, but they can secrete any of the adrenal hormones. So tend to be large. An average size on CT for the adrenocortical carcinomas is about 10 to 12 centimeters. Various factors on the CT which suggest carcinomas, such as irregular borders, irregular enhancement, calcifications, necrotic areas with cystic degeneration, and on the non-contrast, they tend to have a reasonable Hounsfield unit of around 39 as average, to differentiate from adenomas, which are generally less than 10. MRI is a good modality as well for looking at these masses, and they do take gadolinium up quite well. But again, an MRI is very useful to looking at surgical planes to see if they're locally resectable. A PET is FDG PET is fairly standard for the adrenocortical carcinoma. They're very avid, and this will pick up any metastatic deposits as well. Generally speaking, they're not biopsied to make a diagnosis. There's a significant risk of seeding. And with the biochemistry, which is very thorough, and the radiology, there's enough evidence there, and the risk of it being a cancer to take it out. So the management of adrenocortical carcinoma is mainly surgery. So if it's resectable, then we'll take it out. Different to some other cancers, if there's metastatic disease, there's still a benefit from resection. So if from a symptomatic point of view and a biochemical point of view, there can be benefit. But it does have a high recurrence rate whether it's fully resected or not. So around 60 to 80% are likely to recur. And the treatment, really, the oncological treatments for it is something called mitotane. But it's 5 years of therapy, and there's evidence that it can help. Generally speaking, it's very hard to tolerate for the patients, and they may not get through the whole course. It it lyses the adrenal tissue, so they will have some adrenal insufficiencies. So they'll be under the endocrinology team for steroid replacement. Cytotoxic chemotherapy is the next line. Even so, they tend to present late. They're fairly aggressive tumours, and the 5-year survival rate really reflects that, of between 20 and 47%. So what we'll all see often when we request a scan is an incidentalloma on the CT, and there's not that much agreement with, or consensus on many things with the adrenal glands, but for incidentalomas, there tends to be a consensus that masses over 1 centimetre should be looked into further and investigated. Those under 1 centimetre are generally not followed up. Quite common, so about 4% on CT will have them, and as we get older, they'll be increasingly common. If there's bilateral adrenal lumps, then obviously there's other things to consider, such as spread to the adrenal glands from other cancer sites, bilateral pheos, hyperplasia. If that's the case, then it's probably worth getting the endocrinologist involved quite early on. Incidentalomas tend to be active about 12%, which is why they're not more discarded as just incidental lesions. Pheochromocytomas in 5%, Cushing's in 5%, but the Conn syndrome is very rare, and even rarer the androgen secreting tumours. It's mainly the pheos and the Cushing's which we'll look for, and if there's high potassium, then obviously a screen for Cons. So CT's, again, probably the first line of investigation, and often where these things will be found. The difficulty with incidentalomas is they'll be found on a CT or a scan done for something else, and it depends on the phase of that scan and how useful they are. Ideally, we'll have a non-contrast phase, and then if it's less than 10 Hounsfield units, we can be fairly happy it's benign. 30% of adenomas, however, are more dense than that. They have a Hounsfield unit above 10. That tends to be the lipid poor ones, but they do rapidly wash out of the contrast. So if they have a characterization scan for an adrenal, they'll have a non-contrast CT to determine the baseline Hounsfield units, and then have a delayed phase and to see how quickly the contrast is washing out. So that's a contrast phase, of course. The MRIs can be done again to characterize the pheos if needed, and PET if there's a suggestion of pheochromocytoma or cancer. If there's really doubt in the diagnosis, then a biopsy can be done, but really it's got to be done after the exclusion of a pheochromocytoma, as we said earlier. So size-wise, as we said, incidentalloma is anything over 1 centimetre. If they're 4 centimetres, then the CT is quite good at picking up most of the ones which are carcinomas. As you get over 6 centimetres, the chance of it being a cancer are much higher, up to about a quarter. If they're smaller, so 2 centimetres or less, and hyperdense, so those low Hounsfield unit ones, then they're really quite unlikely to grow with a low threshold. Well, they'll probably be followed up, but with less concern. So these get sent through to the endocrinologists, and they'll send the specialist nurses off to do the initial screen, and if it really to go in to do the metanephrines to make sure there's not a pheo. I generally have an overnight dexamethasone suppression test, and those two things will be the baseline biochemistry screens. If there's evidence of hypertension or hypokalemia, then the renin-aldosterone is also measured. So the approach that tends to be taken for these incidentalomas is, depending on size and obviously on the biochemistry, but if we go for the size, really, if it's over 6 centimeters, they are considered malignant until proven otherwise. And to prove otherwise, it generally needs them to come out. So we would if the patient's otherwise fit and well. 4 to 6 centimeters is quite controversial, but there seems to be a consensus, and one we'd follow is if they're fit and well and they've got a good other adrenal gland, then we ought to tend to take them out to get the definitive histology. Under 4 centimeters, it will depend on the patient, it depend on the growth kinetics. And there's various guidelines of how these should be followed up and how to act if they do change. So a pragmatic approach, say if they change over a centimetre in 6 months, then consider taking them out. Others would say a slightly smaller size. And the protocols for following them up do vary place to place. So NIH would suggest 2 CTs 6 months apart. Other authors have said 2 years of follow-up, so 6, 12 and 24 months. There's very little evidence behind them. Something we've not mentioned before, we do see quite often myelolipomas of the adrenal. They can be characterized radiologically fairly with quite a lot of certainty. Don't take an awful lot of those. I've taken a couple out just because they've been quite large and possibly symptomatic, but if there's any loin pain, it's quite hard to be certain that this is the true source of any discomfort. So adrenal surgery is slightly odd field because as a surgeon, we get involved really with the endocrinologists, and they do nearly all of the investigation work. So I'm often sent a patient with everything done and a request for an adrenal lump to be taken out. But I get referral from endocrinology. This is generally what I end up doing, is the referral comes from endocrinology, and in Exeter we've got a couple of the adrenal endocrinologists who are really good and contact me quite regularly, or when I contact them quite regularly about the patients. We'll put everything through the endocrine MDT. I'll then see the patient in clinic, discuss the surgery, discuss the risks, and send them a patient information sheet. When they come in for surgery, they get consented, of course, but the general risk of any laparoscopic surgery, the things that specific for adrenal surgery is that they may need steroid replacement post-operative, and that's no matter the cause of the reason we're taking the adrenal out. Quite often we've taken adrenals out because of their size and often be non-secretory, and we do a cortisol the next morning, and actually the cortisol is low, so there may well have been a slightly increased level of cortisol, which is subduing the other side. So the patients are cancer, they may need steroid replacement post-op. Obviously, if they're bilateral adrenalectomy, then they'll definitely need a steroid replacement for life, and they go through an education process for this, as well as what it means day to day, and if they get ill and the precautions to take. If there's a pheo, then they are cancelled as to a risk of recurrence, and they're monitored for that lifelong. I work with 2 specialised anaesthetists. At least the recommendations from the Endocrine Society are that there's at least 2 anaesthetists in the department to do it, just to allow planning for surgery with absence and leave, etc. So I work with one or 2 anaesthetists for each list. The patients in a lateral position, I put them over the brake, and I do all my adrenals with the robot. We've got the XI now in Exeter, which I've had for a few months. So to put 4 8mm ports down the mid-clavicular line, and an air seal port, which heats the pneumoperitoneum and allows instruments and things to be placed inside. And so with 5 ports, I tend to do it. I do all mine transperitoneal. So obviously you can do them retroperitoneally, you can do them just laparoscopic, you can do them open. I found this technique to be fairly robust and very straightforward so far. What I would say is the left and right adrenalectomy tend to be very different operations. The right adrenalectomy is very much dissecting off the IVC and the renal vein for 45 minutes or so, and that's about it. The left side is more about mobilizing the splenic flexure, mobilizing the spleen, and then getting down on top of the aorta to bring the adrenal up. So they're very different with the structures you're operating on, and very patient dependent, mainly depend on the patient's BMI. We'll talk about some of the anaesthetic considerations in a moment. Post-op wise, if they're FEO, they tend to go to ITU to monitor them, and that's generally because of blood pressure monitoring. It's quite hard to get a level of monitoring on the ward where they might be having a dip in blood pressure due to bleeding, or if it's due to the lack of adrenaline floating around. And a patient we did a few months ago had a very active FEO, a low ejection fraction on an echo, and he spent a long time in ITU post-op. I think in retrospect, it turns out the only thing keeping his heart pumping was his heart blood pressure up at all was the huge amounts of adrenaline surging around the system. So he stayed in ITU for quite a while and eventually got off, but hasn't done particularly brilliantly. They can eat and drink, mobilise. In all patients, do a 6 a.m. cortisol, because as I said a moment ago, they do tend to, even the non-secretory ones may have a dip in cortisol post-op, in which case they can have some hydrocortisone while things settle out. So the perioperative management of adrenal surgery is led mainly by the endocrinologists, and then it transfers to the anaesthetist. So the endocrinologist will correct the electrolyte abnormalities, associate any hypertension problems, any hyperglycemias. We try and get on top of as much as possible. When we're considering the FEOs, generally speaking, they'll be started on an alpha blockade. So doxazosin is the most common one now. It's alpha-1 selective. Some patients are started on phenoxybenzamine, which is a non-selective alpha blocker. It tends to be started more with the anaesthetist once the patients are admitted. And in Exeter, we're still admitting patients 5 days before the surgery, which is quite a long time. And they'll be placed on escalating doses of phenoxybenzamine until the point in which they're having a postural drop in the blood pressure, at which point the anaesthetists are happy that they're suitably blocked. Our anaesthetists tend not to beta blockade them, and only really if the tachycardia got arrhythmias, then that's needed. One important thing that anaesthetists are aware of is not to use dexamethasone for an antiemetic during the anaesthetic, and that's really because we'll go on to do the cortisol in the morning afterwards to see if they're needing steroid replacement, and the dexamethasone obviously will throw that out if that's the case. So that's the gist of the adrenal side of what we do, what I do. So I've got a couple of cases just to highlight a few bits, if that's okay. I think we've just got a few minutes. If there's any questions, just let me know. So first case is a 49-year-old builder. He had an ultrasound scan, I think, for loin pain, which found a 9-centimetre mass above his right kidney. He was fairly pragmatic man, didn't really complain of any problems, but when they dug around or you asked him specifically, he does have episodic symptoms of headache, sweating, palpitations. Actually, when he went on to measure his blood pressure at home, he's having periods of high blood pressure. He was screened and came back as having raised plasma and urine metanephrines. And you remember I said earlier that generally speaking, you don't really need both. You have the plasma if they're up above the limit of normal by 2, then we're happy. It is a FEO, but often they get everything thrown at them, and they've had every test you can think of. So that was done. He had a CT then, to look for the source of this, and he's got this lump here above his right kidney. So this is obviously quite a dense structure, 57 Hansford units pre-contrast, so we know it's not an adenoma. portal phase 1 through 3. And after the 10-minute delayed phase, there was a degree of washout, but not full washout. So it's a bit indeterminate. But I think with that mass and with the biochemistry, that it's fairly certain this is our pheochromocytoma. It is large. There's a risk of malignancy. It's 9 centimeters. So he had an MIBG to go and look for other sites. I don't know how well that's coming across. Hopefully you can see it, but you can just see the right adrenal mass being very avid. There's some uptake on the left adrenal. This was thought to be physiological, although with no true evidence of that. But it was thought maybe it's probably physiological, and just keep an eye on it. I think he's been fine since. So we took his adrenal out, and actually the surgery was fairly uncomplicated. Anesthetically, it was more challenging. And you see on the BP chart here, it just swings as the blood pressure is going up and down. It goes up as I'm prodding it or manipulating it. It needs to get a bit more control. It shoots up again. And the next screen from here, you just see it starting to come down. Then it really just sort of levels off once the adrenals mobilize fully. The adrenal vein is clipped. Often we'll clip an adrenal vein and they'll still swing around a bit. There's usually a couple of other small vessels just to get rid of it fully, but the main swings are when you've got the full adrenal vein fully attached and you're just trying to get under the adrenal to get it mobilized. Histology for him came back as a 9 centimeter pheo. It wasn't not confirmed malignant, but of course there's no definition really histologically of a malignancy for a pheochromocytoma. They use a PAS score, which again isn't really a hard and fast rule. He got a PAS score of 4, and the 4 does give you a risk of a more biologically active tumour and potentially distant met. So he'll go on to have annual screening with his catecholamines and just make sure they're not going back up again. It's a fairly good marker for recurrence, if that's the case. So the second lady, and this is the last one, a 29-year-old woman who looked in generally fairly dreadful when she came to clinic. She got type 2 diabetes, hypertensive, she's overweight, previous spinal surgery, and really it's the spinal surgery is why we found a lump in the adrenal gland. But she came to clinic with a lot of the clinical signs of Cushing's disease, such as overweight, which is all fairly central. She had a lot of abdominal striae, moon faces, thin skin, but she had a lot of edema as well. Her legs were big and full of fluid, and the skin was dreadful. She had the dexamethasone suppression test and came back as most likely Cushing's syndrome from that. She had a USP, so a raised urinary steroid profile, and this is a newer test really. It's not very specific to any cause of adrenal pathology, but it seems to separate out adenomas and non-adenomas, so it can be raised with various causes, whether that's Cushing's or cancer. But it's not it's a bit controversial at the moment, and it's used by some endocrinologists, but not all. She was found to have a right adrenal lesion on the MRI of the spine, which is why I said the previous spinal surgery and ongoing spinal problems brought this to light. And it's only on the spinal surgery that it picked up the imaging. The referring centre, I think she may have been a Torbay patient, commenced on metyrapone. We don't usually see this much. It inhibits release of cortisol by inhibiting one of the enzymes in the adrenal cortex. Don't generally start patients on it much, but this one was because she's in such a bit of a bad way. I don't know if that MRI is coming across very well, but you can just make out the mass above the right adrenal gland. She underwent fairly straightforward surgery. Histology came back as an adrenocortical tumour. And to score the tumours, they use something called the Weiss criteria. Again, it's not that specific. And there's a whole load of histological criteria they use to score. Scores over 3 are considered malignant, so genocortical carcinoma, and those with less than 2 benign. Hers was 1, so she'll just go on to some monitoring, and I think mainly clinical endocrinologists will follow her up. She had quite a low cortisol post-op, commenced on hydrocortisone, and generally speaking, they'll have 20 milligrams in the morning, 10 milligrams at lunchtime, 10 milligrams in the evening, and that will be weaned off over the time. I saw a couple of months post-op, and she had made quite a massive improvement. She lost 20 kilograms of weight. Her skin was better, diabetic control was much better, and she's off antihypertensives. So some of these young patients with really good going Cushing's, you can make a real significant difference to their day-to-day life. So overall, I think there's a few take-home messages. Incidenomas are common. Really, decision making is aimed at determining whether they're cancer or functioning, in which case that we take them out. And the work really is very closely with the endocrine NDT and good endocrinologists, to the point where, to be an adrenal surgeon, you could probably get away with not knowing any of what we've just talked about for an hour, apart from how to take them out. But it's quite nice, and you can join in the MDT if you do know a bit more. And the key message I'd say, really, don't biopsy an adrenal mass unless a fear has been excluded. No dexamethasone during the anaesthetic, and do a post-op cortisol the morning after adrenalectomy. And that was all I was going to say, but if there's any questions at all, just let me know. I was going to say it's quite hard to see adrenal surgeries. There's not that many, but you're very welcome to come along to our theatres in Exeter if you want to see one or two.
Feel free to put any questions in the chat as well, everyone, if you want. But thanks for that, Mr. Dutton. That was really useful. I think it's an area that's can be quite difficult to get your head around, and that was definitely in the sort of straw poll at the start. That was the topic that lots of people wanted covered. We appreciate it.